Good morning, my respected teachers and my fellow colleagues. Today's presentation's topic is heart-lung interactions in critical care. I am Dr. Pallavi Saha, DRNB CCM PDT. The cardiorespiratory system provides oxygen for whole organism. Therefore, by a complex interplay, heart and both the lungs, they work as a functional unit. So, as per the historical aspect is concerned, 3 centuries ago, the English physiologist Stephen Hales, he observed that the level of the blood column in a glass tube which is inserted into the carotid artery of a horse, it varied cyclically with different phases of respiration. So, this was the first recognition of the mechanical interplay that might have been there between the respiratory and cardiovascular systems, which is nowadays referred to as heart-lung or cardiorespiratory interactions. So, if we try to define it, it is the complex interaction between the cardiovascular and respiratory physiology as a result of the phasic changes in intrathoracic pressure during different phases of respiration. It occurs like as the heart is encompassed by the lungs in the juxtacardiac fossa and all are encased within the rigid chest wall. So, the heart, it acts like a pressure chamber within a pressure chamber. To understand the heart-lung interactions, we should start with different definitions which we day-to-day basis use, like preload. Firstly, it is the passive stress at the end of diastole of the ventricle. There is a formula which is Laplace-Young formula. The stress or the preload is defined as pressure into radius by 2 into the left ventricular thickness. So, the preload defining factors are these. Next is afterload. Afterload is total myocardial stress during the left ventricular ejection. The determinants of left ventricular afterload is the systolic pressure, the radius during systole and the wall thickness. Systemic vascular resistance, it reflects the vasomotor tone of the cardiac circulation, the systemic circulation. Another concept is transmural pressure. I will be explaining it with a graphical representation in the next slide. Transmural pressure is defined as the internal expanding force and external collapsing force, the difference between these two forces. Left ventricular transmural pressure, if we can, as we remember that the heart is a pressure chamber which is encased within another pressure chamber. So, the left ventricle, when the left ventricle is defined as per the transmural pressure, the transmural pressure of left ventricle can be defined as the intracavitary pressure of the left ventricle itself minus the pericardial pressure. The transmural pressure is an important determinant of the left ventricular afterload. Similarly, the transmural pressure of alveoli is the transpulmonary pressure. If we can see this image, it is a schematic depiction of right atrium. Right atrium encased within the thorax and the pericardium. So, the intracavitary pressure of the right atrium is measured with fluid filled catheters against the atmosphere. If we try to understand the transmural pressure of the corresponding to the right atrium, it can be defined as the pressure difference between inside of the right atrium and the surrounding pressure of the thoracic cavity, that is the pericardial pressure. The transmural pressure PTM is, so the right atrial pressure defined as the blue line minus the surrounding pericardial pressure, that is defined in the green line. Same principle applies for the transpulmonary pressure, which is the difference between the alveolar pressure minus the outside pleural pressure. Next is mean systemic filling pressure. As per the Frank-Starling curve is concerned, though I will be describing the mean systemic filling pressure in the curve also. It is defined as the mean pressure in the central circulation during a no flow state. So, the mean systemic filling pressure and the blood volume relationship, they follow a linear curve. The curve is described in the next slide. There comes the concept of unstressed blood volume and stressed blood volume. Unstressed blood volume is about 60% of the total blood volume that can be easily accommodated within the circulatory system without causing any vessel wall stretch. And if there is any vessel wall stretch due to any additional volume or any kind of volume overload strain, then the rest 40% that can be also accommodated within the circulatory system, that is the stressed blood volume. If we schematically depict it, this is the schematic depiction. The volume inside a vessel at near zero transmural pressure, where there is no flow state, without the vessel walls are under no stretch, that is depicted with the color blue, that is the unstressed volume. It fills the system without exerting any tension in the vessel wall. The other red circumference, that is the stressed blood volume, it creates positive transmural pressure via the elastic recoil of the vessel wall itself, that is termed as stressed volume. This curve I was previously talking about, that the mean systemic filling pressure and the blood volume, they follow a linear curve relationship. Next topic is ventricular interdependence. The physiological state where function of one ventricle is affected or determined rather by the dynamic changes of the other ventricle. There are two effects that might be parallel independence or that might be series independence. Ventricular independence in parallel, when there is two parallelly presented ventricle with an interventricular septum in between. So due to sharing of the interventricular septum as well as the pericardium, this effect is parallel ventricular independence. And there is series ventricular independence, that the interdependence, that is due to variation in the preload as well as afterload. These all effects comprise into the heart-lung interactions, that is a complex procedure. I will be explaining it further. Next is venous return. Venous return, there is another schematic depiction of venous return curve and the cardiac output curve, which is I will be explaining. Venous return itself depends upon the gradient between the mean systemic filling pressure and central venous pressure divided by the right atrial pressure. It is a passive process. Mean systemic filling pressure, as we have seen with blood volume, it follows a linear curve at a no flow state. And stroke volume is, the determinants are preload, afterload and myocardial contractility. Now I will be describing the contractility and Frank-Starling curve. As per the Frank-Starling curve, the theorem is myocardial work, it varies with the initial length of the myocytes, cardiac myocytes. Pre-stretching of sarcomeres, they result in more vigorous contraction, but there is a maximum effect. After that, if we further stretch the sarcomeres, the stretching will no longer increase or they will possibly reduce the myocardial work. Thus, we can depict there is a stroke volume with preload, there is a relationship. In this graphical analysis, there are two curves I have already accompanied in single presentation. As we all can see, the blue one is venous return function curve, the blue one. And the Frank-Starling or cardiac output curve that reaches a plateau after a certain stretch is depicted as black. So, in different physiological surroundings, how does the curve change? We will be learning that now. As the curve is already, I have explained that the blue one is the venous return curve and the black one is the cardiac output curve, this one. So, the intersection between the two curves, that is denoted as the black point, that is the black one, in an equilibrated system is the right atrial pressure. The venous return function curve, when there is no blood flow, at zero blood flow, it intersects the x-axis. This is the blue one, I think everyone can see, this is the mean systemic filling pressure at no flow state. if there is volume responsiveness, so the venous return function curve, that blue one, it shifts upwards and to the right and it reaches a new equilibrium. That is the dotted blue line. And then the RAP is also grey. Previously the RAP was the intersection of the two curves, that is denoted with the blue dot. Then the curve is shifting when there is volume responsiveness, the venous return is also increasing and the RAP is also shifted upwards and right. In case of spontaneous inspiration, when the patient is inspirating on its own, the pleural pressure drops and the RAP also drops. The curve shifts, the cardiac output Frank-Starling black curve, they shift to the left as the transmural pressure rising. As we can see, the transmural pressure is the difference between the either the right atrium pressure minus the surrounding pressure. So the transmural pressure will increase as the pleural pressure during spontaneous ventilation is decreasing. New equilibrium is reached and the dark green, I think we all can see, the dark green one intersecting point is the new RAP. And with mechanical inspiration or positive ventilation, positive pressure ventilation, the opposite happens. That is depicted with the dotted red line.
Sorry, can I just go back to the curve? So, when you take an inspiration,
yes, sir.
What is happening to the cardiac output? Left, right ventricular.
Sir, during the patient is taking a spontaneous inspiration.
Yeah, we are talking only about spontaneous inspiration.
Yes, sir. So,
cardiac output curve right ventricular na left ventricular.
স্যার এই কার্ডিয়াক আউটপুট মানে এই নিচে যে এক্স অ্যাক্সিসে যে প্রেসারটা দেখানো হয়েছে সেটা এটার জন্য রাইট এট্রিয়াল প্রেসার দেখানো হয়েছে।
এই যে কার্ডিয়াক আউটপুট যেটা দেখানো হচ্ছে,
কার্ডিয়াক আউটপুটটা স্যার এটা লেফট ভেন্ট্রিকুলার।
আচ্ছা, এটা তুমি আচ্ছা লেফট ভেন্ট্রিকুলার, that is the confusing because when you take an inspiration, your the transmural across the right atrium pressure drops.
Right atrial pressure drops.
So the mean systemic pressure to right atrial pressure difference are body. So there is increased venous return.
Yes, sir.
So the right ventricular output increases. The right ventricular mean systemic venous return eta bhabchi. So, but if you draw the cardiac output curve of the left ventricle, now that is actually, if it is shifting from the black to the green, that means it's actually dropping. But that is due to other reasons. That is not due to this inspiratory increase in.
So that is transmural pressure rise korche during the spontaneous inspiration. So the transmural pressure as well as the gradient of right atrial pressure defining that MS mean systemic filling pressure minus the central venous pressure. সেটাও বাড়ছে।
Flow to the right atrium বাড়ছে, তাহলে flow to the right ventricle বাড়ছে। Right ventricular flow বাড়লে right ventricular stretch হবে, তাহলে right ventricular output actually বাড়বে. So if you let us assume that this is the right ventricular function curve, তাহলে it will shift from shift to the right.
সেক্ষেত্রে রাইটে শিফট করবে।
এই diagram actually it is correct, but if you say that this cardiac output is of the left ventricle, কিন্তু সেখানে তো অন্য মেকানিজম চলে আসছে যে কেন হার্ট, if we take it as one organ, venous return বাড়ছে, reload বাড়ছে, কিন্তু cardiac output কমছে during inspiration. That is
it's a more complex. বুঝতে পারছি।
So this is actually cardiac output curve for the left ventricle.
Left ventricle. So shift করুন।
During inspiration, right ventricular afterload বাড়ছে। That is a complicated issue. Basically, process গুলো বলেছে যে the right ventricular afterload will actually depend upon the pulmonary vascular resistance, and the pulmonary vascular resistance curve is a U-shaped curve. And so if you have a baby on ARDSA, it's all collapsed. So So you have a high coronary vascular resistance, which is predominantly due to hypoxia. Whereas if you increase, মানে আমাদের নর্মাল ব্রিদিং আমরা এফআরসিতে যে ব্রিথ করি সেখানে ইট ইজ দ্য লোয়েস্ট, বাট যদি আমার লাংস স্ট্রেচ হয় তখন আবার বাড়বে। সো ইন এফেক্ট বিকজ অফ দিস কম্বিনেশন এই রাইট ভেন্ট্রিকুলার আউটপুট খুব বেশি করে না যদি না পেশেন্ট ভলিউম ডিপ্লিটেড থাকে বা রাইট ভেন্ট্রিকুলার ফাংশনটাই এফেক্টেড থাকে বা পালমোনারি হাইপারটেনশনটা ডিসপ্রপোর্শনেট কোনো কারণে থাকে। সো ওখানে the impact on the left ventricular output is predominantly due to your interventricular
dependence. And also the failure state also in a interdependent. If there is a failure state, first a right ventricular failure, that will also propagate to left ventricular failure.
ঠিক আছে, বাট মানে আমি বলছি এই গ্রাফে this curve is actually more at the left ventricle সেটাই আমি ভাবছি তুমি মেইন সিস্টেমিক ফিলিং প্রেসার বলছো, রাইট ভেন্ট্রিকুলার প্রেসার বলছো, প্রিলোড বলছো, দ্যাট ইজ টু দি রাইট ভেন্ট্রিকল, যে তুমি রাইট ভেন্ট্রিকলটাকে ধরে বলছো না জাস্ট হার্ট অ্যাজ আ হোল বলছো।
স্যার চেঞ্জ কর
প্লিজ।
So the magnitude of heart-lung interactions thus depends mainly on 4 changes. The effect of phasic variation in intrathoracic pressure on the larger vessels and cardiac chambers. Next is the effect of change in lung volume on the pulmonary vasculature. Thirdly is the changes occurring due to the ventricular interdependence. And lastly, the effect of changes in intra-abdominal pressure due to diaphragmatic displacement on abdominal vessels. I will be discussing all the 4 points in the next slides. Firstly, the effect of changes in intrathoracic pressure on preload and venous return. So when a patient is spontaneously breathing, the intrathoracic pressure is reduced. So the gradient, as I have discussed, the mean systemic filling pressure minus the CVP, central venous pressure gradient, is increased due to the decrease in intrathoracic pressure. So the venous return, which depends on this gradient, is also increased. Preload of right ventricle is also increased and right ventricular output also increased. During the mechanical ventilation, the opposite of this phenomenon happens. So the gradient of mean systemic filling pressure minus central venous pressure, this falls, resulting to decreased venous return, decreased RV preload and decreased RV output. On ventricular afterload, the effect of intrathoracic pressure is, as I have discussed, the transmural pressure is defined as the intramural pressure of a specific cavity, it might be a chamber of heart, minus the outside pressure. During the spontaneous breathing, the outside pleural pressure is negative, the intrapleural pressure is negative. So the transmural pressure rises as per the difference is concerned between the intramural pressure and minus the negative intrapleural pressure. So the addition of both leads to increase in the left ventricular afterload. Previously I have described regarding the right ventricular functions. So there in spontaneous breathing, the left ventricular afterload increases, thereby the left ventricular function gets reduced. In case of positive pressure ventilation, as I am giving the patient positive pressure from outside, the intrapleural pressure, previously it was negative in case of spontaneous breathing, but in case of positive pressure ventilation, the difference or the transmural pressure is reduced than as it was in the spontaneous breathing part. So the LV afterload decreases and LV function improves. That is a basis of management of in case of cardiogenic pulmonary edema or in case of obstructive sleep apnea, any other physiological components that needs the LV to function more. We can try the positive pressure ventilation as a therapy. So as I have described, in case of spontaneous breathing, the venous return, it increases, LV afterload also increases, left ventricular afterload. Thus, there is increased intrathoracic blood volume due to the venous return getting increased. In case of positive pressure ventilation, the venous return decreases, just the opposite things happening. Thus, the LV outflow increases as the LV afterload is getting decreased. That there is decreased intrathoracic blood volume, so patient can there is occurrence of hypotension with low cardiac output. That can lead to sympathetic stimulation, that can lead to tachycardia and vasoconstriction. Thus, as we have described, there is unstressed blood volume and stressed blood volume. So, due to vasoconstriction and sympathetic stimulation, the blood volume from unstressed part, it gets recruited to the stressed part. Thus, the physiologically human body maintains the cardiac output. In case of hypovolemia, in case of anesthetic medications, and in case of weaning from mechanical ventilations, there are different changes in the intrathoracic pressure as well as the preload and venous return. I am describing it on later slides. Next is due to changes in the autonomic tone. So, if we give a positive pressure ventilation with an appropriate tidal volume, then patient may there might be vagolytic effect if we are giving the patient the appropriate tidal volume. But if we are giving the patient more than necessary, excessive tidal volume, like more than 10 ml per kg, that might lead to bradycardia and vasodilatation. Also, positive pressure ventilation may affect the vasomotor tone as such that there might be increased prostaglandin synthesis and there is salt and water retention, and patient might gain weight due to positive pressure ventilation, due to the salt and water retention. Next topic is effect of changes in lung volume on cardiovascular system. During positive pressure ventilation, as we are providing positive pressure from the outside, there is squeezing of the pulmonary capillaries. So, there will be transient increase in the left atrial blood volume. Also, there is increase in the intrathoracic pressure as I have described. So, there is decrease in venous return and decrease in the output. The LV afterload is increasing, but the right ventricular output is getting decreased. So, positive pressure ventilation, it leads to compression of heart in the cardiac fossa with reduced diastolic compliance. That can further aggravate if we use high PEEP or other recruitment maneuvers like we use in during positive pressure ventilation, that can further aggravate. On peripheral vascular resistance, the main determinant is right ventricular afterload. As I have described that peripheral vascular resistance, it can rise due to hyperinflation of the lung or alveolar collapse. The right ventricular afterload, that if we use right ventricular afterload as the sole determinant of peripheral vascular resistance, during hyperinflation of lung or positive pressure ventilation, there might be rise in peripheral vascular resistance. Oh, sorry, pulmonary. Yeah. Pulmonary vascular. Pulmonary vascular resistance. Due to also the squeezing of the pulmonary capillaries also.
So do you have the graph where you plot the lung volume versus this resistance area? Which I was mentioning in the U-shaped curve presentation with us.
আমার শুধু ফ্র্যাঙ্ক স্টার্লিং কার্ভ উইথ ভেনাস রিটার্ন এই কার্ভটা আছে।
Because what I would suggest is this is a very good endeavor and very good topic, is one of my favorite topics. কিন্তু I understand what I just shift presentation to the one, but your presentation can be your sentences can be to the point, write less amount of the slides,
yes,
and try to speak more, try to include more graphs, more graphical representation, which will be more catchy for the audience. Cardiopulmonary interactions with FRC, we basically demonstrated with that FRC card. You plot your lung volume against your pulmonary vascular resistance, how it dips gradually, and then it's like a U shape, as I was saying, and then it goes up. Similarly, you have something called waterfall phenomenon, and that's something which you are trying to describe here. multiple nomenclature, but probably out of RV afterload বোঝানোর জন্য there is a concept called rest zone of lung, যেটা বিভিন্ন forms of mechanical ventilation আমার zone 1, zone 2, zone 3 মধ্যে can toggle between the zones, so that can also be demonstrated. তারপরে transmural pressure সেটাকে demonstrate করার জন্য you have I would suggest for the next time এগুলোকে আরো বেশি ক্যাচি করা। The sentences can be small. They can be like you can easily cut down on whatever you have written and speak more.
Okay. So continue for it.
And following, like for everything, you have to mention about the RV and NV. There's a table format, like so during inspiration, effect on RV, effect on NV.
Acha.
Otherwise, there is very confusing. Sometimes you are saying about the RV and sometimes about NV. It should be incurred during inspiration, during spontaneous, effect on RV, preload and afterload, and effect of NV preload and afterload. Then on during PDD, effect on RV preload afterload, NV preload afterload. Otherwise, this is very confusing. Your slides. Okay, continue.
Why does the PVR increase? Can you explain a bit more? Why does the PVR increase? Why does it go down to it has an RD and then it again goes up? Why does the PVR increase at very high lung volume? And why is there an optimal lung volume where PVR is least?
Okay. Graphical.
The predominant mechanism when the lung is completely collapsed is hypoxia. That is causing pulmonary hypertension. And as you start to ventilate and give a little bit of blood pressure or heat, etc., the cardiomyopathy is in normal patients there. Ventilate kori, কিছুটা পিক দিয়ে করি 5-6 পিক দিয়ে আমরা অ্যাডাল্টস করি শুয়ে থাকলে বেসিক অবস্থা। So that keeps the pulmonary pressure to a useful level. Airway resistance and peak ওটা counter করা, that was, people used to think that this is the mechanism. But when you overinflate, often there is mechanical issues that come in, that's the stretch the capillaries, mechanically your resistance goes high. If your resistance goes high, then your RV afterload increases. So much ekta sort of happy peak was there. You had your curve U-shape it. So it helps. It keeps the RV outflow optimal.
Just in the same lines what sir said. So as he was mentioning about mechanical factors gradually coming to play. So theoretically there are two types of blood vessels or capillaries in between the alveoli. One are called the septal vessels and one would be a corner vessels. So what are they? So basically alveoli, lung you can consider as a combination of millions of alveoli. Right? So they are like walls. And if your lung is completely collapsed, then what happens is all these vessels are also crushed. You can imagine like all the walls are completely collapsed and also these capillaries are completely collapsed between the walls. You gradually inflate the lung with some pressure, say P. You gradually inflate. Now these septal vessels are the vessels in between the wall of the capillaries and the corner vessels are, so these are like hexagonal structures and the corner of the hexagon you have these corner vessels. So when you gradually inflate, both of these capillaries also inflate, the septal vessels and the corner vessels. At a certain point of time, they will be optimally inflated, the lungs as well as the blood flow to the capillaries, and that is your area of least PVR. As you go on to increase your lung volume more and more, now the blood vessels within the capillaries, they become crushed. They are crushed just because of mechanical forces, because of septal vessels. So the PVR again rises. It increases more, now the corner vessels also get crushed. The PVR rises.
Next is ventricular interdependence due to series effect, and as I have described, the preload and afterloads, they come into play. during positive pressure ventilation, the RV preload and the RV outflow also they gets reduced. We have described. So effect reflected on the left ventricle after every 3 heartbeats. This is the series interdependence, and this is known as the pulmonary transit time. After every 3 heartbeats, the left ventricular function is also gets reflected. The changes gets reflected on the left ventricle. With these phasic variations that can be measured during as per the stroke volume variation or the pulse pressure variation, there are different curves during spontaneous breathing and as well as during mechanical ventilation. The stroke volume variation and the pulse pressure variation curves are also there. Clinical implication, if there is no right ventricular failure, so these phasic variations, they indicate that the left ventricle, as the curve is described, left ventricle is on the steep portion of the Frank-Starling curve. So the preload dependent patients or the venous returns that can be gradually increased if we give the patient, if we correct the patient's volume depletion, then the curve, the Frank-Starling curve denotes the volume responders also. But the caveat is these phasic variations can also occur if there is volume overload state in the right ventricle, then also the similar phasic variations can also happen. And in case of ventricular interdependence in parallel, when due to the sharing of the interventricular septum as well as the pericardium, if the left heart becomes a high pressure system, so if the high pressure system of the left heart, it leads to the interventricular septum to bulge inside the left heart. Then right ventricular, there is also acute rise in the right ventricular pressure. The right ventricle dilates and it tries to accommodate the extra blood volume. That leads to the restriction of the pericardium. Outside pericardium movement is restricted. Then IVS, the interventricular septum, it bulges inside the left ventricle more, and it leads to decrease in the left ventricular output as well as the outflow. And thus it leads to, firstly there was right ventricular failure, then it ultimately leads to the left ventricular failure due to this parallel interdependence and sharing of IVS as well as pericardium. Due to diaphragmatic displacement, when there is positive pressure ventilation, due to positive pressure ventilation inside the lung, there is more rise in the intrathoracic pressure, and that leads to the caudal displacement of diaphragm. If there is caudal displacement of diaphragm, there is rise in the intra-abdominal pressure. If the intra-abdominal pressure rises, it compresses the splanchnic circulation. But if the patient is not in volume depleted state, if there is no hypovolemia, then the intravascular pressure is already more than the intra-abdominal pressure. Thus the venous return and the mean circulating blood volume is maintained. But if the patient is volume depleted, if the patient is already in hypovolemic state, the intravascular volume is very low, then the intra-abdominal pressure increases or exceeds the intra-abdominal pressure in this state during positive pressure ventilation. Thus the veins collapse and the patient's mean circulating blood volume further decreases with positive pressure ventilation. So during the clinical uses of heart-lung interactions, we can use this to assess the preload reserve and volume responsiveness. With spontaneous breathing, with each spontaneous breath, the increasingly negative pleural pressure, as I have described previously, during inspiration the pleural pressure gets negative during spontaneous breathing, and with each breath the further increase in the negative pleural pressure, it leads to the inspiratory drops in the curve. And the during mechanical ventilation, this pattern is reversed. Thus, there is prediction of fluid responsiveness based on ventricular interdependence, and we can also use the factors like pulse pressure variation or stroke volume variation. Also, the decision to administer fluid is based only in patients with features of circulatory insufficiency, if there is any. Because the caveat is the stroke volume variation and pulse pressure variation with the changes in venous return and also the phases of inspiration, that can also happen if the patient is in volume overload state also. Next is to identify the preload responders. It was previously suggested that if there is any decrease in the central venous pressure of more than 1 millimeter of mercury, it was suggested to be a preload responsiveness. But it doesn't actually tell how much the left ventricular outflow or the cardiac output curve is near the flat portion of the Frank-Starling curve. But as per the pulse pressure variation curve I have described, if there is any inspiratory drop absent, that indicates the heart already is in the flat portion. Next is weaning.
This was like the classic thingy, but there have been studies like showing that a CVP they have fluid responsiveness. It is all over the place. Graph and we call them sort of static measures of fluid responsiveness. From CVP ho or tomar wedge pressure ho. They don't. It will be like a 50-50. So it doesn't really tell you whether the patient is fluid responsive.
The more dynamic.
Use করে এসেছি অনেক বছর ধরে এখনো আমরা ইউজ করি বলি না কিন্তু there are studies which have clearly shown that measuring CVP, there are people who say don't measure CVP, but there are others measuring CVP CVP দেখে fluid responsiveness assess করা is like a toss of a coin. It is also the case with using Pallavi wedge to measure fluid responsiveness.
So the dynamic parameters are more in use right now.
That is correct. So we did marker of preload responsiveness. As a historical note, we both
more in our day-to-day ICU practice, we use the passive leg rising test as in recent studies, the head tilt is also another dynamic parameter of fluid responsiveness.
Sticking to what you have said on the slide, what others are available, etc. Issue for
Weaning from mechanical ventilation. Weaning is itself a stress exercise for the heart and lung. It can be seen as a cardiopulmonary stress test. When the patient is trying to breathe, the breathing of work is gradually being returned to the patient, and weaning is increased with an accompanied with an increase in the cardiac output also. But if the patient fails the weaning trials, left ventricular end diastolic pressure that is increased due to the excessive stress, and if the patient fails weaning, there is mixed venous oxygenation that might drop, which leads to myocardial stretch, myocardial ischemia, that further can lead to diastolic dysfunction and further may lead to pulmonary edema.
Just to figure out, I have some problems with some of this actually. Weaning is accompanied by increase in cardiac output.
If the patient is, if the blood flow is gradually being returned to the patient, that
it depends on what kind of physiology you are dealing with.
In a normal heart, it will not have ailing heart. So what you are trying to say is that the weaning puts a load on the heart, and the heart will be able to compensate for that load by increasing its cardiac output.
yes.
But the crux of the matter is that when you fail weaning, we focus on the pulmonary parameters, respiratory rate, etc. But the moment you take the patient off positive pressure ventilation, positive pressure reduces afterload, so it facilitates left ventricular outflow. So the moment the patient is now on spontaneous breathing, generally the ventilator breathing patient there is tachypnea, there is a lot of intrapleural swings, and the afterload actually goes up.
Yes, yes.
And afterload up only that left ventricular pressures will barbate, so that is an excess load on the heart, and the heart will not be able to take that. At the inspiration swings you draw in more into your right ventricle, and so that increases the right ventricular filling. Press onto the interventricular septum onto the left ventricle. So you get high left ventricular pressures, left atrial pressures, pulmonary pressures, and the patient can go into heart failure, pulmonary edema. So weaning failure can also happen if the patient has a weak heart, other than the lung parameters. So at pneumonia chilo, lungs but the patient can still fail a spontaneous breathing trial because of a leaky heart. So weaning is accompanied weaning puts a load on the heart, which the heart should be able to take if healthy. If not, then it will not release to increase in cardiac output, release to drop in cardiac output, increase pressures, pulmonary edema, and your failed weaning trial.
During our day-to-day ICU as per the ICU patients, there are some patients who get overnight CPAP. When we try to wean the patient in the morning, when we try to remove the mask, suddenly there is a respiratory distress and the patient's saturation gets dropped. The same thing.
Yeah. Which is why we wean patient on NIV nowadays. COPD certainly, but even the other cardiac patients also. And it's the same. But today we're managing acute pulmonary edema. So furosemide and GTN and morphine are not the number one tick for managing pulmonary edema. It is putting a mask on and giving CPAP or BiPAP, because that immediately reduces the afterload, and that improves cardiac output, and the pulmonary edema tends to settle better. There's no improvement in survival unless you immediately crash for except in COPD patient, but it is one of the best treatment for acute pulmonary edema. It supports the heart. So pulmonary edema patient are weaning problem, they are two sides of the same coin.
And what are the effects of rise in left ventricular endoscopic pressure?
If the heart is already weak, or if there is failing heart and the patient has already cardiac issues beforehand, though there might be increased incidence of myocardial oxygen demand supply imbalance. The mixed venous oxygenation may further drop, and the patient that might lead to myocardial ischemia, and the ventricular dysfunction might aggravate.
How can it lead to myocardial ischemia? Dropping of mixed venous oxygenation is secondary to decrease in cardiac output.
Yes.
So how does it impair myocardial perfusion? Increase in left ventricular endoscopy. Mathematically.
Sir, the heart gets its blood supply during the diastole. So if there is diastolic.
So mathematically, your coronary perfusion pressure drops.
Yes.
Coronary perfusion pressure, like there is a formula, but basically it's your diastolic blood pressure minus your left ventricular endoscopic blood pressure. That's what it is. So if your diastolic blood pressure is constant, and if your endoscopic blood pressure
increases,
blood pressure goes up, so obviously your coronary perfusion
it will decrease.
To maintain a good coronary perfusion pressure, you need to have at least around 12 to 14 millimeters of mercury. That's what the mathematics is. So if you have somebody, like we obviously are pediatric cardiac artery, so our range of blood pressure is much lower. But for our children also, like we often have like severe cases of left ventricular failure, or sometimes in cases of severe right ventricular dysfunction. So we have very low diastolic blood pressure. So we are very vigilant about the diastolic blood pressure. We don't want the coronary perfusion pressure to get compromised. So that is the mechanism of myocardial ischemia.
Yes.
when left ventricular diastolic pressure rises. Similarly, when you have somebody with very poor ventricle, you have them put on ECMO. Then also you have to make sure that despite now you have a consistent ventricular, now you have a consistent cardiac output, because ECMO is giving you the cardiac output, you have to vent the left side of the heart, because unless you vent the left side, your diastolic pressure will still go up, and despite being on ECMO, the heart will not recover because coronary perfusion failure. That is the so that is why your cardiac output reduces further, and that is the cause of dropping in venous saturation. So not the other way.
So change korbo. Next is the management of cardiogenic pulmonary edema. So we should try to give optimal PEEP, positive end expiratory pressure, so that the FRC is maintained and the pulmonary vascular resistance is reduced, improving the right ventricular function. Positive airway pressure, if we give it from outside, it increases the pericardial pressure, so the transmural pressure of the left ventricle, it gets reduced, leading to improved left ventricular ejection and cardiac output. That leads to decrease in the symptoms of cardiogenic pulmonary edema. During obstructive sleep apnea also, if patients sorry, in a patient with obstructive sleep apnea with a closed glottis, they exhibit increased inspiratory muscular efforts, creating a strongly negative intrapleural pressure. So that is transmitted to the intrathoracic large veins and pulmonary vasculatures, and it leads to increased venous return because the permanent, progressively increasing negative intrapleural pressure, that leads to increased transmural pressure also. That leads to further dilatation of the right ventricle, and the pulsus paradoxus concept comes there. If there is a weak heart, if the heart is already failing, so then the patient cannot sufficiently adapt to such changes during progressively increasing negative intrapleural pressure. That can further lead to RV diastolic dysfunction and RV failure.
Yeah. So when you have a patient who has heart failure, you're optimizing them. That is one of the things that you have to have in mind here. Do sleep study. You can get other sleep disorder breathing patterns in heart failure as well, but this is one. Similarly, if you have a patient with resistant hypertension, they have already puncture you've excluded the other usual secondary causes, then you can look at obstructive sleep apnea, and sometimes your blood pressure will normalize, heart failure will improve when you give them CPAP.
Yes.
In pediatric morale, do that with a foreign body, because the inspiratory swing will be phenomenal. Large airway failure, obstruction, heart failure. But that can precipitate like an acute or pulmonary.
Same for epiglottitis.
Yeah, it's a large airway obstruction. But intrathoracic pressure fluctuation and impact.
Due to this obstructive sleep apnea or any other upper airway obstruction, that is the basic concept of negative pressure pulmonary edema. That can also aggravate the right ventricular diastolic dysfunction. Is that change good? During these episodes of progressively increasing negative intrapleural pressure due to negative pressure pulmonary edema, that can further lead to cor pulmonal, and after the RV failure or RV diastolic dysfunction, that further actually lead to left ventricular dysfunction in cases of if the patient's having severe obstructive sleep apnea. So the nocturnal positive pressure therapy, positive pressure ventilation with CPAP, that helps to keep the upper airway open, and it also reduces the daytime sleepiness as well as improves the cognitive skills of the patient. Thank you.
So what is pulsus paradoxus?
Sir, during the closed glottis, if there when the changes in the afterload with the progressively increasing negative intrapleural pressure, the
paradoxes to describe which you can actually show us আগে তখন এই আন্তঃশত প্রেসার so both and it is pulses paradoxes. So তুমি সাইডে তোমার বিষয় বুঝা so what is pulses paradoxes?
কিভাবে বলবো স্যার মানে নর্মাল চেঞ্জেস পালস প্রেশার ভেরিয়েশন যেটা নর্মালি মানে
নরমালি শ্বাস নিলে আমার পালস কি হয়
স্যার ইন্সপিরেটরি ড্রপস হবে মানে পালস প্রেশারের ইন্সপিরেটরি ড্রপস হবে হ্যাঁ ভলিউমগুলো ড্রপ করবে
ভলিউমটা ড্রপ করবে তাই তো প্যারাডক্সিক না আমি এখন আমরা এক্সপ্লেনেশন গুলো জানি কিন্তু যে ভদ্রলোকেরা ডকুমেন্ট করেছে এটা খুব স্মল যার নাম হলো সাইন্স আছে যারা রানিং years ago so with inspiration there's a drop in blood
that volume
pulse disappear করে দিতে পারে সিস্টেম আর সেটাকে কোয়ান্টিফাই করতে গেলে তোমাকে ব্লাড প্রেশার নিতে হবে সিস্টোলিক ব্লাড প্রেশারটা কতটা ড্রপ করছে নরমালিও একটু ড্রপ করে 10 এর বেশি হলে আমরা ওটাকে তখন ডিফাইন করি আর কজেস দিচ্ছেন সো you go with spontaneous breathing inspiration এ তোমার রাইট ভেন্ট্রিকুলার ফিলিং বাড়ে কাটে বিকজ অফ ভেন্ট্রিকুলার ডিপেন্ডেন্স the left ventricular output কমে that is the explanation ঠিক আছে so normally we are hot but it is not really significant unless you have a situation where you will have hypovolemia and that we shall become American effusion severe asthma is swings গুলো যদি বেশি হয় more than the normal rate তাহলে you will be more than
exaggerated responses হবে
what is reverse pulses paradoxes I mean you see if you go through the history of it ওরা তো খুব সিম্পল টুলস নিয়ে এগুলো ডকুমেন্ট করে দেবে it helps you understand so তুমি যখন পজিটিভ প্রেসার ভেন্টিলেশন করছো যে চেঞ্জেসটা হবে সেটা রিভার্স pulses paradox so এই যে মেকানিক্যাল ভেন্টিলেশনে when you have put in a detailed presentation তুমি এতটা পড়েছো কিন্তু মানে খুব সিম্পল টেক অ্যাওয়েটা কি হবে যে রাইট ভেন্ট্রিকুলার লেফট ভেন্ট্রিকুলার কি হবে রাইট ভেন্ট্রিকুলার প্রিলোড নরমাল ইন্সপিরেশনে বাড়ে কিন্তু পজিটিভ প্রেসার ভেন্টিলেশনে it will reduce so that will have an impact on cardiac output etc কিন্তু ওটা সিগনিফিকেন্ট হয় না কম্পেনসেশন হয়ে যায় because the right ventricular left ventricular afterload is affected opposite একটা afterload বাড়ে একটা afterload কমে আমি একটুখানি পজিটিভ প্রেসার ভেন্টিলেশন দেওয়া so unless there is hypovolemia or vasodilatation due to anesthetic drugs etc it does not make a huge difference কিন্তু তোমার যদি লেফট ভেন্ট্রিকল গন্ডগোল থাকে তাহলে that afterload will have a toll on the so some effects are undesirable or serendipitously some effects have become desirable যে তুমি এটাকে ইউজ করছো না for treating pulmonary edema you're weaning off patient when you're struggling then you give positive pressure using an NIV because at the end of the day what you're wanting to do is oxygen delivery so তুমি একটা পেশেন্টকে ভেন্টিলেশনে দিচ্ছ because they have toxic hypercapnia etc respiratory কিন্তু দেখবেন এই হিমোডায়ানামিক আনস্টেবল হবে আমরা চট করে ট্রিটমেন্ট করি তাই তো that is because at the end of the day the oxygen delivery is a function of both the heart and the lungs right so that is the simple message I mean fluid responsiveness is a different chapter
ওটা আবার নেক্সট টপিক করা
ওটা that's a different it's a little bit more thank you very good
sir what is we are outside means positive pressure ventilation is how it acts on heart so সেটা যদি বলতে হয় তাহলে তো অনেকটা বলতে হবে
মানে দেখো অনেকটা বলতে হবে দুটো ডায়াগ্রাম একটা ওরকম এঁকে দিলে সুবিধা হবে সেই এফেক্ট অন রাইট হার্ট এফেক্ট অন লেফট হার্ট এফেক্ট ডিউরিং মানে দ্যাট ইজ অল
আমি যেটা বলতে চাইছিলাম যেটুকু বুঝলাম মানে একটা তো বলছি যে পজিটিভ প্রেশার ভেন্টিলেশন in simple sentence বলতে গেলে it is bad for right side of the heart good for left side of the heart
bad কি করে বলবো যে suppose somebody is on ARDS and if he is involved the lungs are maybe collapse তুমি তাকে যদি পজিটিভ প্রেশার ভেন্টিলেশন দাও তুমি তো তার পালমোনারি ভাস্কুলার রেজিস্ট্যান্স কমাচ্ছ সো তোমার ভেন্টিলেট করার উদ্দেশ্য তো গ্যাস এক্সচেঞ্জ সো আনলেস ইউ ডু দ্যাট হবে কিন্তু আবার বেশি
সিওপিডি বা
হ্যাঁ সো বেসিক্যালি ব্যাড বলতে পারবে সো অন দ্য রাইট হার্ট it involves the venous return. The effect on the pulmonary vascular resistance depends on the lung volume temperature ventilating. So depending upon the disease, depending upon what technologies etc. you're using, very good. A left hearted is a little bit positive pressure, afterload improved. That is the key of it. So positive pressure delay bhalo hoy, ar tumi positive pressure theke jokhon soraccho, তখন you have to be prepared for a bit of a hit. মানে diabetic diastolic dysfunction মানে হচ্ছে you have got cor pulmonale. So cor pulmonale patient it becomes complicated there you don't মানে get এগুলো কিছুটা তো মানে বোঝানোর অর্থে আর সিম্পলিফাই করা people have complicated hearts. মানে যারা 70-year-old smoker who probably also be diabetic hypertensive he will have cor pulmonale but he will not have a very healthy left ventricle too. So you will struggle. আর পরে তুমি বুঝবে যে পাস প্রেশার ভেরিয়েশন হ্যান্ডটা হলো মানে if somebody is got cor pulmonale then ওইগুলো ওখানে প্রডিউস করা যায়
আমরা যখন বাচ্চাদের প্রচুর আমরা আরটি ডায়াস্টোলিক ডিসফাংশন নিয়ে ডিল করি অবভিয়াসলি সেই পেশেন্টসে যেমন আপনি বললেন তাদের লেফট ভেন্ট্রিকুলার খারাপ
হ্যাঁ
ওভারঅল হার্ট খারাপ কিন্তু আমাদের দেখতে হয় আমরা যেটা নিয়ে খুব বেশি দেখি যে মিন এয়ারওয়ে প্রেশার আমরা কত হচ্ছে
হ্যাঁ
তো আই ডোন্ট ওয়ান্ট মাই মিন এয়ারওয়ে প্রেশার টু গো স্কাই হাই
হ্যাঁ
তো সেইভাবে আমাদের কিছুটা টাইট্রেট করতে হবে because we understand that this is helpful for the left side of the heart at the same time ventilating too hard will be also harmful for the right side. So it's a balance because you need to ventilate this space at the same time you need to understand that if you ventilate too hard it will not beneficial for the right side also. আমরা typically mean airway pressure around 12 এরকম তার বেশি আমরা টার্গেট
see and other thing the lung suppose you get somebody with pneumonia একটা রাইট আপলো বিশাল pneumonia রয়েছে we treat them মানে it will affect the different alveoli differentially বুঝতে পেরেছো so in a zone concept the west zone এর concept আপনি খেয়াল রাখতে হবে যে at the end of the day it is the global oxygenation that should improve যেগুলো নর্মাল alveoli সেগুলো স্ট্রেচ করবে নর্মালি আপনি যেন ওখানে হয়ে যাবে ড্যামেজ হবে বায়োট্রমা এটসেট্রা হবে আর যেটা সলিড কনসলিডেটেড হয়ে আছে ওটা হয়তো খুললোই না যে প্রেশারটা দিচ্ছে হ্যাঁ if you've got a diffuse condition then it will affect everything a little bit more uniform
আর একটা যেমন ছিল ইন গ্যাস্ট্রিক স্টেট মানে কোনো পেশেন্ট সাধারণত যে শ্বাস নিচ্ছে তখন তো ভেনাস রিটেন ইজ অ্যাকিউটলি ইনক্রিজিং সেখানে রাইট ভেন্ট্রিকুলার ভলিউম এতটাই বেড়ে যায় ইটস রেডিয়েট দ্য সেপ্টাম
সেটাই তো একটু বলা ঠিক যে কথা বলে না যে epiglottitis etc. a foreign body but even in a severe asthma a severe COPD regime when asthma they won't because they tell the younger patient whose musculature is good so they are able to generate more pressure and a old COPD patient he will probably just collapse and go into a cardiac arrest situation ওই যে swings গুলো তখন they can precipitate acute coma তখন এই swings গুলো eliminate করতে হবে তো তুমি মানে যে positive pressure ventilate করলে patient stable হলো you have to think what stabilized him মানে you are preventing him harming himself by taking away those swings so you're supporting his heart and এখন যে ventilation apart from lung support it is also supporting the imbalance that is the interesting bit because at the end of the day আমরা এখন কাজে কিছু কথা কিন্তু at the end of the day it's oxygen delivery